Dr. Ibrahim.
Here.
Lee Johnson. Dr. Lakey.
I am here.
Dr. Martin. Dr. Martinez.
Here.
Dr. Maxwell. Dr. Mayer. Dr. McCullum-Smith. Dr. Mitchell.
Here.
Dr. Newport.
Here.
Brittany Nichols.
Here.
Dr. Oliveira. Dr. Pliska.
Here.
Dr. Podewiltz.
Here.
Olga Rodriguez.
Here.
Sue Shell. Dr. Scott.
Here.
Dr. Suarez.
Here.
Dr. Thompson.
Here.
Dr. Wagner.
Here.
Dr. Williams.
Present.
And Dr. Watson. Welcome, Dr. Watson.
Thank you. I'm here.
Okay, that
Lee
quorum.
Johnson? Did you get Lee Johnson?
Oh, I didn't get Lee. Hi, Lee.
Hey there.
Okay, that should be 20.
Very good.
Actually, 21.
Very good. We have 21 individuals here, so we are at quorum. Again, thank you everyone for spending your Monday with us. It's President's Day, and so several of our members couldn't be with us today, but again, I appreciate everyone that could be here for being here. Dr. Watson, welcome to the Mental Health Care Consortium. Do you want to introduce yourself and say a few words as we begin?
Absolutely. Hello, I'm Patty Watson. I am a psychiatrist by training here in College Station at Texas A&M. I was appointed to the interim head of the Department of Psychiatry and Behavioral Sciences on Friday, so I have a steep learning curve ahead of me, and I'm looking forward to this meeting.
Very good. Well, welcome. It's good to have you here. And again, it's great to have everyone here today. A couple of ground rules as we start. One, please do not use the chat function because we're following the Open Meetings Act for Texas. If you put something in the chat box, the people that are viewing this can't see that. And so what happens is you have to hear me read off your comments. And so would ask people not to do that. No one wants to hear me read those comments. Second, if you're going to leave, we're kind of tight related to our quorum. And so please give me a heads up beforehand. There's a couple of votes that we need to do, and I want to make sure those are done and before the meeting ends. And again, I think we're going to be okay, but we should be okay. I guess Luanna's telling me we have a couple other people that have joined. You want to call?
Yes, Sue Shell.
Yes, here.
Sarah Martin. Dr. Martin.
Here.
Thank you.
Thanks.
All right. Very good. I don't think we're going to use all the time that's been allocated to us today. I think we can get done relatively quick, but there are a couple of important things that we need to vote on and go over today. So with that, the first item of business, we need to approve the minutes from the January 22nd meeting. Please take a look at those minutes if you have not looked at them already. And if you have, if somebody would make a motion for approval and second that, we can go ahead and move forward.
So moved, Podewiltz.
Okay.
I'll second it.
Okay. Motion by Podewitz, second by Dr. Suarez. Any further discussion? Hearing none, all in favor signify by saying A.
Aye.
Hey,
Opposed, no. Anybody abstain?
Dr.
Hearing
Watson.
none. Yeah, abstain. Okay, it's good. Not being here at that last meeting.
Right.
Very good. So they are approved. The next part of our agenda is to get the presentations and update from our evaluators. And we're going to start off with the University of Texas at Austin as our internal evaluator. And why don't we, let's see, Lachelle is putting up the slides. And I think Molly has the presentation. Dr. Lopez?
Thank you, Dr. Lakey. Good morning, everybody. We are excited to join you here today and tell you a little bit, just kind of share a few of the data points. We're going to focus in today a little bit on TChat and bring in some of the current data points from that. So next slide. So we all know that we have spent several years really focusing deeply on expanding TChat across our state. So here are our current data points as of December 2023. We are covering 3.8 million students with TChat services and have 70% of those student lives covered by TChat currently. We've got 778 schools and over 778 districts and over 6,000 schools enrolled in TChat. And you can just see graphically from the map, we are covering the state in many ways. I want to dive a little bit deeper into that 70% of student lives, if you'll hit enter and the next slide. So what does that actually mean? So here is exploring sort of our enrollment a little bit further. So you can see in the blue that 70% active in TChat currently. And then in our other pieces of the pie, we've got 7% that are currently in that process of onboarding with the HRI, working on the MOUs, working on getting training to the schools so that they are ready to go with TChat services. We've got about 11% of students covered by districts who have declined to participate right now. And the most common reason we see for declining to participate in TChat is because the district has other services in place that they feel like are meeting their students' needs around school mental health. We've got another about 7% of districts covering students' lives. So the 7% is of those students that the district or campus is not responding to outreach. And that category doesn't come into place until an HRI has made multiple attempts to try to reach out. And including, we've been really relying on ESCs for those districts and campuses that are harder to reach. So really, when we think about kind of who is left for our continued expansion, it's that 5% that we have down in the red part of pie, that planned group. So these are campuses where either the HRI hasn't yet engaged with that campus or hasn't hit that time of multiple outreach, so just trying to kind of get them involved in the process. So a really small amount, which is really exciting to share that we've gotten to that place. So a little bit more about who those people are. As you can see, we've got, sorry, I just kind of lost my Zoom there. Okay. As we can see, the majority, about half of the districts are elementary schools. And then secondary schools are the next most common, middle schools then, and a small number, as you might expect, of those really usually rural or charter schools that represent multiple grades across the area. So I do have a couple of highlights to share on this area. We do have 4 districts, which is really exciting, that have reached now 0 in their planned column, which is really exciting. So a big shout out to University of North Texas Health Science Center, UT Health Science Center San Antonio, UTMB, and UT Southwestern Medical Center. All of those HRIs have no students left in that planned status area. So everybody is in one of those other categories as a part of their outreach. And then all of the HRIs are doing really well, and none of the HRIs have over 15% of students remaining. So we really truly are kind of at that point of just a few left to look at. Very exciting. Next slide. So here is where we are as we're thinking about sessions that are being provided. And what you see here is kind of year on top of year, the growth in the number of TChat sessions by month. So across FY22 and then FY23, we saw significant growth. And as you can see in the beginning of FY24 through January, we are seeing even more substantial growth over the previous 2 years. And you can see our January has been quite significant. And as we predict, in comparison to other months, you would expect to see some continued growth over February, March, April, and May, and then we'll see the summer months with a little bit of a decline again. So seeing a lot of sessions happening and really busy HRIs. Next slide. So what are those services that are being provided? In terms of the number of encounters that young people are seeing. So this is a breakout of the number of encounters at the end of care for children who have discharged from care. And this excludes case management only services. So it's really capturing our assessment and treatment services. So you can see about half of those children have gotten between 1 and 4 encounters along the way. Then we've got about a quarter that are receiving 5 encounters, which is kind of traditionally how we've thought about TCHAT. And then another 25% that have gotten more than 5 encounters in care. And in the chart on the right-hand side, you can see the distribution of those encounters over 5, with most children getting 6 to 10 encounters, and then it quickly declines after that point. Okay, next slide, one last slide. I always like to share as well a little bit of an update of what we're hearing from our parents in our satisfaction questionnaire. So here's a few of the comments that we're seeing that we see multiple times. So they're a bit of a trend, and just some reflections on those. We certainly see in our question, and we actually ask about what ways we can improve. So the question is specifically targeting opportunities for improving. And we see quite frequently people express that they really wouldn't change anything and that they're very satisfied with services. So in that first one, a parent expressed that they had a great experience with their daughter's counselor. She really learned a lot and that TCHAT had helped them. We also frequently hear the need for some flexibility in services. This parent shared, please have weekends and times past 5. That would be very helpful for parents to be able to attend more often. And parents also sometimes share their desire to have more sessions and to be able to see the counselor or other providers a little bit longer. And then again, a lot of good things to say as well. So that was kind of what I wanted to share today a little bit, and just appreciate all of the hard work y'all are doing. It is showing up in your data. It is showing up in how busy I'm sure your providers are with the growth that we've seen in TCHAT.
Very good. Thank you, Dr. Lopez. A couple of quick questions, if I may, start off the discussion. On the slide with the number of sessions, one of the things that our team, as we're trying to look through, why there's been that significant increase over the last several months, it looks like there may be a little bit of a change in how we're classifying there. It looks like a lot of case management sessions have recently been added by some of the institutions. And so our team working with you, I think we'll be looking at that so we can be clear of how many of these are case management sessions and how many are full kind of first encounters. But it's tremendous growth there, either way. But it does look like there's a little bit of that difference on how some things are being reported than maybe in the past. Do you have any insight on that?
Well, we've had a pretty short period of time in which we've had that opportunity to record case management services and trait. This particular analysis, though, does exclude those that are case management only. So I did take those out to make sure that we were really seeing just those assessment and treatment intervention services.
Okay. And then one other quick question on the slide with that you had the pie charts, and 5% were planned, and in that you had 3% elementary, 1 for middle school, and 1 for secondary. Is that by number of schools, or is that by student population?
It's by student population.
Okay, very good. Thank you.
Mm-hmm.
Any other questions for Dr. Lopez? All right. Seeing none, again, thank you, Molly, for all the work. And again, tremendous work by all the HRIs. It was 11,000 sessions in January. That's pretty incredible. So thank you. Let's now move on to the external evaluation from the University of Texas School of Public Health, Houston.
Thanks, and I'll be presenting it today, but we're all here for questions. So we're going to report some of the findings from our surveys with CPAN providers and the TCHAT providers in schools. So if you want to go to the next slide. So this is based on survey data, and just briefly to orient you, our surveys focus on for CPAN enrolling the physicians involved with the program and in the last 12 months. So the sample we identified was from a diverse sample from across all the HRIs. And we also made sure to include clinics, physicians from clinics that are serving vulnerable populations based on our vulnerability index in the air for the geographic areas. And we had a response rate of about 30%. And so just to orient you to the overall support and enthusiasm for the program, 98% from our quantitative data reported they would recommend CPAN to other providers, and 96% intended to continue using CPAN in the next 6 months. And I want everyone to keep that in mind as we go to the next slide, which is our qualitative findings. And so here we're going to represent themes that emerge from open-ended responses. So we asked questions to probe them on what were some barriers you may have encountered and how can the program be improved. And again, these are qualitative, and we ask these so we can look at themes, and then next year we can follow up to understand them with more quantitative data. But what we've learned from the themes that we're seeing is that using a content analysis of the open-ended survey responses, we asked providers, okay, what's your biggest barrier? And in the spirit of quality improvement, we looked at these. And like last year, the most prominent barrier that were identified was that emerged was time constraints. So as busy care providers making calls to CPAN looked like some were saying it disrupts our workflow and requires additional time built into our schedule to allow for consultations. And providers didn't always have time to wait for the callback from CPAN about a particular patient. So you can see that in a quote that represents that theme. Consults can be helpful, but are harder to fit into clinic flow. Can't wait for callback if I'm seeing patients. So this is from one pediatrician, and there is a variation of this thought where we'll look later quantitatively is how widespread is this? Is it particular to certain HRIs? Is it coming from one or more? And then how can we improve on that? So we looked at how can the CPAN program be improved? And these are some of the thoughts that providers wrote into that open-ended response. Some respondents noted that improving connections to community resources and referrals can make CPAN a stronger program. Specific requests included updating referral lists to offer more affordable and viable resources for the uninsured and underinsured patients, and ensuring the community resources are accessible. So one thought was offering more telehealth options for underserved patients who can't travel far during work hours and relevant to patients' needs. And then finally, respondents expressed in some themes that emerged, improved outreach and awareness of the program. This could help improve buy-in and support at clinics, enroll more providers across the state, and better inform the institution about the role CPAN is playing in the mental health care. And we thought this was an interesting one. We know that the social marketing communications team is really working hard on this. So you can see that that's, the providers see that as an important influence on other providers joining. And so we think that's an important one to share. And we can see again which HRIs these responses are coming from, because these are volunteer write-in responses to open-ended questions. So the quote you can see for that was, "I think a lot of community providers do not know about CPAN. I learned about it through a coworker. I believe greater community outreach into pediatrician offices in the community would ensure more people knew about this program." And so that was from a physician assistant. So if we move on to the next slide on CPAN themes that are the benefit, the biggest benefit. So here we can see kind of the flip side of some of the barriers that emerged. So similar to last year, an important benefit theme that emerged was accessibility of the CPAN program. Respondents specified that the accessibility of consultation services, information, and resources provided by the CPAN program helped them to better address the pediatric mental health needs of their patients. Further, the list of community resources tailored by patient zip code was reported as helpful and reduced the burden on physicians. Providers also reported that CPAN increased their confidence in treating patients with mental health needs. The program has allowed physicians to care for patients without the need for a referral or to bridge their care until they can see a specialist. This we saw was reflected in quantitative findings as well in our survey. Another theme that emerged was the perception that education and training provided by CPAN was beneficial. Specifically, several participants mentioned that the opportunity to continue medical education credits through CPAN's presentations and training opportunities was valuable. A quote for this was, "It is an amazing resource. It is very beneficial to run cases by a psychiatrist. The referrals are great because they take patients' insurance and location into consideration. They are non-judgmental, very helpful, and their advice and support make a huge positive impact on patient care," reported by a pediatrician. And then what, if anything else, surprised you about CPAN? And this was some of the common themes that emerged. Many respondents indicated that they were most surprised by how easy and efficient CPAN was to use. While time constraints were identified as a barrier, most respondents indicated that they were pleasantly surprised by response time and how easy it was to receive professional consultation from a psychiatrist when needed. Respondents were also surprised that the resources and referral lists received were tailored to their patients. And a quote for this theme was, "Very quick response, both by phone and then with resource lists. Nothing else related to consultation support happens this quickly and efficiently." And that was from a pediatrician. So you can see that we're finding, the experiences and the qualitative were beneficial, but also some things that we can learn from in growth areas, and that could be specific to certain HRIs, which we can improve. And then I'm going to move on.
How are you doing today, sir?
Oh, sorry. I don't know if someone was asking a question. We still have T-chat slides, and then we can do questions, or if you want me to pause, I can take questions.
No, Laura, I think you can go ahead and continue.
Okay.
I think that was accidental, and so I'd ask
Okay.
other people to please mute your microphones during the presentation. Thank you.
Got it. Okay, no problem. Okay, we'll move on to T-chat then. Okay, same kind of flow. While we have a lot of quantitative data, we're focusing on the qualitative today, but to orient you to the context, this was a survey conducted amongst school staff. Again, we got where our goal was to get a diverse sample of users enrolled in across the HRIs based on the rural urban charter classifications of schools, economic disadvantage, and district size. There were 483 campuses represented, and we ended up having 226 school staff respond, and that was a 49% response rate. And we're going to explore in our themes the same kind of thing: barriers and recommendations and strengths. But to orient you, the quantitative data showed us that nearly 90% would recommend TChat to other schools. 93% intend to continue using TChat in the next 6 months. So you can see that overwhelmingly positive feedback from the quantitative data. But I'm going to move on now, just going more into the qualitative themes. So using the open-ended approach, and again, a content analysis of what people voluntarily responded to these probes. I'll start with the responses to the probe. How can the TChat program be improved? And so some of the stronger themes that emerged was respondents reported that the TChat program could be improved with a more efficient referral, enrollment, and scheduling process, accessibility of forms, completing paperwork, and the need for a parent for school counselor in some cases to be present during sessions has been an issue for some families. Some respondents also noted the referral and scheduling processes for school staff can be burdensome. Recommendations included making the referral process simple, providing an easy consent and intake process for parent engagement, and improving the scheduling process. For example, standardizing using an online scheduling system. The external evaluation team will be doing interviews with HRIs later this year, and we're going to look at the best practices that we can identify across that HRI, since there is a variety of systems in place. And so we're hoping to learn more about this to give more feedback and recommendations. That's just a side note. So another theme that emerged was respondents would like improved communication and follow-up while students are involved in the TChat program. Specifically, some respondents indicated that they would like updates on the case status, for example, whether a student received a service or not, and outcomes and recommended follow-up care, including connections to community resources after all sessions are completed. And then another theme that emerged was a desire for more TChat providers and sessions for students. Some respondents indicated that wait time for TChat sessions have been longer as demand has grown, so increasing the number of available clinicians would be beneficial. This is especially true for the rural districts with limited resources. So you can see the quotes for some of these. It would be nice to get updates on students receiving services. The school could help to follow up and ensure that the parents connect with the local provider to continue receiving care. And that's from a school administrator. And then a counselor noted, our kiddos are being seen right away. This is so helpful to our families, and we're so grateful. And so many of them are grateful for the free services they would not have received otherwise. So you can see that there may be some areas here to think about communicating expectations with what can and can't be shared back to schools. And we know that that has been something that has been top of mind and been worked on, but we thought we would share that because it looks like you've already been addressing an important theme that has emerged in our work. And I think it's really great to see that you've already been kind of activated about how can you address that. So I'll stop there. I know that's been a little different from our other presentations in that we're focusing on qualitative findings. So just want to reiterate, we're going to be using this to help us focus this year's survey questions to look more into the feedback we're seeing these themes.
Very good. I think that's very helpful. So let me open it up to everyone. Any questions or comments from the executive committee? Olga?
I just wanted to confirm and follow up. You said you were going to be following up with each of the HRIs, and
Yes.
what do you anticipate the scope of that being?
Yeah, so we have surveys each year planned, and it's the same process where we aim to include all HRIs and then a diverse group of clinics and schools within those HRIs. So we spend a lot of time on our sampling strategy, and then do a lot of follow-up. We do have gift cards for respondents because we really want to encourage participation in these surveys because we don't want them to be generalizable. And so that's kind of the methodology. And then we design the survey questions. Some we keep the same so we can see trends over time, but we also want to not be completely repetitive. And so some of the changes we'll make are driven to understand more about the stronger themes and the qualitative responses we got. Yeah, and we do run our surveys by some of the leads of CPAN and TChat, so they can also give us feedback. And they've been really valuable in helping us revise questions.
Great. Just a quick follow-up. When do you anticipate reaching out to the HRIs for these meetings?
Good question. So for the schools, we really want to do it by April because we lose people when schools shut down in May. So we have a tight timeline for those to get sent back out, and then CPAN not too much later. So it's a pretty tight turnaround from year to year to analyze and get the next ones out, but also build on our findings. But those are our goals, and we're getting smoother in our operations each year. Trying to tighten it up. Yeah.
Any other questions or comments? Okay. Seeing none, again, thank you, Laura, to you and your team for that input. I think that's very helpful as we drive quality improvement across the university. So thank you very much. We will next go to an update on the new and emerging Children's Mental Health Researchers Initiative. I'm going to have Nagla give the update. But before she does, just want to let people know that a lot of progress has taken place and a lot of work has taken place. This isn't, there's not an easy button to set up an award system like this. And so Nagla has been spearheading the work with the help of a lot of executive committee members, putting on paper the rules basically for the letting of these dollars, setting up a peer review process. Her and Lachelle have worked to get the computer interface that is needed in order to do this well. And again, we've had multiple conversations with other entities in Texas that provide grant money like this. And again, we want to make sure we learn from their lessons and do it in a way that we can feel very comfortable when we go to the legislature to say that we followed the rules and did this in the best way possible. And so we're coming up to a time where it's going to be opened up. And again, Nagla is getting ready for a webinar for your investigators, and then we'll be opening up the application process. And so Nagla, you want to give us an update on where we are?
Yes. So let me kind of go through some status of where we are, a little bit about the timeline, and just some reminders about what the eligibility looks like. So we released the notice of funding opportunity on February the 12th, and went ahead and put that on our webpage. So where you can find it on our webpage, it is under About, and it is providing it through the acronym, which is NECMHR. Also, we went ahead and shared it not just with our EC members, but also the VPs of research, heads of psychology, and departments, and social work. And so, the more you can share it, the better, keeping in mind also what the eligibility requirements are, which I'll go over in a second. The information on the NOFO, again, and what we're doing is we're holding an informational on the 22nd, which is this Thursday. That's going to be 11:30 to 12:30 Central, and we'll provide information, provide opportunities for people to ask questions, And so far, we have about 56 folks that are registered for that informational session. And then we are working hard to make sure we have all the reviewers in place. So we have 9 out of our 10 external reviewers, plus our nonprofit representative. And we are having an orientation session sometime in March with all the reviewers. Other things in terms of timelines, important dates. The pre-application is set to open on Monday, March the 4th. And other key dates include the full application invitation, which will be April 2nd. Now, to remind you about the process for the application, we're first doing a pre-application. Each HRI is identifying up to 6 applicants that they would like to move forward to the next process, which is the full application. We are encouraging and asking all applicants to speak to their chairs of psychiatry prior to doing the pre-application. And then once we have those 6 identified that each HRI's chair of psychiatry is going to identify as their top 6, we're going to go ahead and invite them for the full application, which again, April 2nd of 2024. The deadline for the application is going to be May the 9th. And we will identify the awardees at our July 2024 meeting. So that's the timeline. Certain kind of just highlights of the research that's eligible and the eligibility requirements is we're only looking at mainly research that aligns with the areas of behavioral health services with the Texas Child Mental Health Care Consortium. So we're trying to make sure that the research is aligned with the priorities of the Texas Child Mental Health Care Consortium. And we've also provided Health and Human Services Commission evaluation priorities. So that's in our notice of funding opportunity. It's in Appendix 1 that people can look at. We've also provided phone numbers for HHSC staff that can respond to any questions related to their evaluation priorities and their programs. Bench research and pharmaceutical clinical trials are not eligible for this grant opportunity. So that's going to be part of the criteria up front is we're excluding anything that is submitted that's focused on just bench research and pharmaceutical clinical trials. Only those affiliated with the Texas Child Mental Health Care Consortium can participate in applying. They can, however, partner. So, and they don't have to be from the Department of Psychiatry. They could be from other departments, but the research has to be reviewed by the chair of psychiatry and approved by the chair, because they're the ones who are going to approve up to 6 applicants to move forward to the next step. Also, institutions can partner with other institutions. In fact, we're encouraging that. And principal investigator can, again, partner with others that are not on the Texas Child Mental Health Care Consortium as well. The prioritization will be for applicants who've never had an NIH R01 grant. And the trainees include clinical and research fellows. We are encouraging that principal investigators dedicate between 25 to 50% of their effort on the grant. And investigators on training grants, we would like them to dedicate between 40 and 50% of their time on the grant. That's all I have, unless you have any questions.
Very good. Thank you, Nagla, again,
Sure.
for all the work to put this together. So it's an exciting time. Again, a lot of things will be happening over the next several weeks with the webinar on Thursday. Again, would ask all the chairs of psychiatry to, again, we're going to be trusting your wisdom to choose the 6 individuals from your institution that will be eligible. And again, they don't have to be in the Department of Psychiatry, but they should be working with you. And so it may be through your School of Public Health, it may be your School of Social Work, some other group. But again, would want to make sure that they are coordinating that work with you as the chair of psychiatry and that they are recommended by you in order to be eligible. We are going to make sure that, again, we're trying to follow best practices. We have a peer review process with individuals outside the state of Texas, so they don't have a conflict of interest or that it's minimized. But we're also going to be working, the research committee will be working to make sure that we have fair allocation across HRIs. Again, I don't want to have to go to the legislature and said we only funded 3 institutions. We're going to try to make sure that we get dispersion across the state of Texas, across systems, and are putting some barriers in place to make sure that that happens. But when we come to this committee in July, it's going to be a full up and down vote of the entire recommendation. And I don't want to have in a public meeting, why this research project versus another research project. I want to be able to vote them all up or down as a whole, so that we can move forward and get these dollars out. And again, I think it's a tremendous opportunity, $6 million, just short of $6 million that will be invested in junior researchers so that they'll be able to, I think, establish themselves as independent investigators and then bring in federal dollars and other type of dollars in the future to help us move the system forward here in the state of Texas. So with that, any other questions for Nagla or me?
Nagla, do we have access to the informational sessions? Have you sent out the link?
Yeah, so you can find that under either events, under the Texas Child Mental Health Care Consortium webpage. And the way it's set up, because it's a webinar, is you have to register for it. And then you can also find it under the About, where again, it's the acronyms of the grant, which is NECMHR, I think. And so if you go there, it'll have a summary of the notice of funding opportunity. It'll have a copy of it, and it will have a place where you can click on it in order to register.
And Nagla, I just talked to Luann and Dr. Babatope. We'll send that out. And again, it's there available on the webpage. But again, we want to make this as easy as possible. And so we'll send that out after this meeting to all the members of the executive committee.
Thank you.
David, this is really a great opportunity for our young investigators. Thanks for bringing it forward.
Thank you, Dr. Suarez. No, I appreciate all the work that you guys are doing. And I hope this will help the junior people at your institution, which is really needed. And so I look forward to seeing the proposals and coming back to you guys in July to tell you about the great work that'll be done across the state of Texas.
Couple of questions.
Yes.
So when you were talking a moment ago about applicants need not be from the Department of Psychiatry, but you said, but they should be working with you. I want to make sure I understand what you meant by working with you. Do you mean working with the psychiatry department chair in coordinating the application, or that the actual research?
They don't have to be doing research together, but the chair of psychiatry should be aware of this, and they'll have to get his approval, his or her approval, in order to be eligible for the funding. Okay. So there needs to be that communication, but not an expectation that somebody in the Department of Psychiatry is on that grant. Grant.
That's what I thought you meant, but just wanted to clarify. And then the other thing is, with a view to not doing pharmaceutical trials and so forth, any thoughts about neuromodulation, like studies that are proposed to do TMS or any brain imaging proposals?
I think so what we've put as the hard stops are clinical pharmaceutical and pure bench. I think that's in alignment with what we've told the legislature we're doing. I think I think for individual grants, it would probably be good to just kind of talk offline to make sure that we feel that that's comfortable, that fits in that, in the, what I understand from the legislature is kind of those perimeters there. Again, want to be very respectful to the entities that they're funding, but that doesn't mean that we're not doing cutting edge research. And again, I think there's ways that we can meet both of those demands. Does that make sense?
Sure does.
Yep. Okay, I'd say 4 hands. And so I'm gonna go in the order in which they're on my computer. Dr. Amador, then we go to you, and then Dr. Martin, then Trivedi, and then Wagner. Dr. Amador?
Yeah, thank you. My question is, yes, hello, can you hear me?
I can, yes.
Okay, thank you. My question is, let's say two, HRIs want to work together on, on a proposal. So then that would mean both of those chairs would have to be okay with it. And then both of those are IRBs, right, will have to be okay with that too.
So the IRB discussion is, I think, a separate discussion than for me. I think, that will be institutional policy. I think the PI that submits it would need to have the chair of psychiatry for that institution to say it's one of the 6 slots that I'm going to use. And again, we would encourage people to partner with other institutions. But, at the end of the day, we're going to be looking at each chair of psychiatry, and they're going to give us 6 names. And that proposal will need to have the PI chair of psychiatry to that put that person on that list of one of the 6. Does that make sense, Dr. Amador?
Yes, thank you.
Yep. Okay. Dr. Martin?
I was just wondering, is this going to be on a regular schedule, like every year or every other year that you're giving out these grants, or do we not know yet?
So what I would like to happen is that we get these grants out. We have great projects. We're able to tell the legislature about it. And then next session that they put in some additional dollars to be able to do it again. And it's part of our work. But we're putting out all the money we have been given this biennium out in this announcement.
Okay.
Does that make sense?
Yes, thank you.
Thank you. Dr. Trivedi?
So thank you. There are 2 points and one where I need your advice. One is because the Youth Depression Suicide Research Network has been functioning and has a lot of players who are being very active and all, I get requests and I need your advice and the TCMHCC advice. They want to put it on top of IDSRN. Should I encourage, discourage, be neutral? Give me your advice, because when I started, I thought I would sort of gear them away from it, but I don't know the answer. So any thoughts you have that would, because we have now close to 2,000 people who we have data on for 4 years. So there's a value that some people see it and they want to put it on top, and I don't know the answer. So
yeah, I think in order to be funded, and again, it'll need to go through the committee and the peer review process, but we are funding those 2 large kind of Framingham type studies. I wouldn't want this to duplicate that work. If somebody has an independent project, a different idea, maybe there is something there, but it would need to be distinct in my mind from the things that are already funded, and provide them the basis to be able to get extramural funds to build upon it. And so that there may be a way that they collaborate with you, but it would need to be an independent project in order to be fundable in my mind. Does that make sense?
Would that be something that I just send them to you or to Nagla or Luann or you and stay out? I just don't want to be interfering as the
Yeah, no, I think they can ask questions during that session later this week. And again, they'll need to get the chair of your department to say that this is one of the 6. And again, big part of that is the mentorship and the development of their ability to develop themselves as an independent investigator. Okay. So if it's just duplicating what you're currently doing, I don't see that as a pathway to become an independent investigator.
This is for people who are asking to do more or different things, but I understand.
But they can collaborate. Yeah.
Thank you. And the other thing, Luann told me I should speak what I said on chat. I think this is amazing, Dr. Lakey. I think what you're creating is a bunch of investigators who will take off and do their own thing. And so I am, as a mere researcher, I am thank you.
Well, thank you. And that's the goal, is that people will be able to become independent and again, not only expand the amount of research that's going on in Texas, but do research that's going to drive the quality of children and adolescent healthcare here in the state of Texas. And I think this is a unique thing that Texas is doing. And again, really grateful to the legislature for allowing us to do this. Dr. Wagner?
Now, just a simple procedural question for you. With the chairs approved up to six applications, where does that process take place? Where do the names get submitted?
We are we're going to do everything through the grant software. And so we have included all the chairs of psychiatry in there, and you will be getting invitations to the software. You'll be able to see all the pre-application submissions for your institution and be able to rate it and then decide which are your top 6 from that. And that's going to let us know, and then we'll be able to review that and then invite them to apply. And so we're taking it out of email. We're trying to do it all into that grant software. So it'll all be together and we can monitor and make sure that it's moving forward.
So the applicants will submit their pre-application first, and then we look at it? But I would
but part of
they should talk to us before the pre-application.
Right. The first question they'll get for the pre-application is, did you speak to the chair of psychiatry? If they did not, then we will kind of direct them to speak to their chair of psychiatry. And so that's kind of how it goes. We want them to speak ahead of time, because part of it, the discussion with their chairs is, does this really align with those priorities? And you can provide them with some ideas and thoughts on how to modify or, kind of add to their proposal in order to make it align with the priorities of both the consortium or the Health and Human Service Commission projects.
Great. That answers it perfectly. Thank you.
Yeah, and Michelle was going to jump in too.
Yeah, I just wanted to say a couple of things. Firstly, just to be clear, although you will be rating the applications and choosing your top 6, when they're having those conversations with you, you can have more than 6 submit the pre-application. And as Nagla said, you'll go in, you'll see all of those and be able to rank them. The second thing that I wanted to be clear on is we will send out a cheat sheet when it comes to the software itself, and then we'll have a session where you can, ask any questions that you have related to how do I go into the system? How do I do this ranking? So we'll make sure that it's very clear what that process is before we get to that point. And then I'll be available if you have any questions or run into any issues.
Yeah, and just kind of to build upon that, Dr. Wagner, there's probably something that's not going to go perfect, okay? But just having been around a while, it's just the way things work. And so maybe a little grace between us, if there isn't something that goes perfect, but we're dedicated to make sure we do this. And so if something doesn't work right, contact us, the chairs of psychiatry, contact us, and we'll work with you to make sure that things get done perfectly. So one quick thing, I noted earlier, and thank you, Dr. Trivedi. I do have to read any comments that get put into the chat box, and so would ask people to say the comments out loud. And Dr. Trivedi, you did this, but Dr. Trivedi noted this is an amazing opportunity for everyone and a wonderful way to bring up new investigators to contribute to the Mental Health Care Consortium enterprise. And I thank you. I just got excited that this is a great program, and so. Dr. Trivedi, I really appreciate your enthusiasm and your excitement, and we look forward to the applications. We have 2 more comments, Dr. Mitchell and Dr. Ibrahim.
Hi, as a training director of our fellowship program, I'm really excited for that opportunity for fellows to be a part of this. I wanted to ask a quick question about the logistics. The timing is interesting for our new round of fellows. We've selected our new fellows, but they won't be here until July or August. So are they allowed to apply for this funding now, even though they're not within our HRI yet, but they will be by the time the funding comes through?
I think that would need to be noted. And again, if the chair of psychiatry says that's one of my 6 slots and that person is going to be there, I would err in saying that we need to consider those individuals and allow that. If somebody feels strongly differently, let me know. But if one of the chairs says that this person will be here and there's a proposal, they'll have to go through the same process. No money will be able to be used for them until they are here. And again, that's something we've also put in. If the individual gets funded and they leave the state of Texas, we're not going to continue to fund them at another institution. This is to build the workforce here in the state of Texas. Okay. Hisham?
Yeah, just a practical administrative question to Nagla and Lachelle. Will there be, and I may have missed this, will there be like a document circulating around that has all these instructions, frequently asked questions, and things like that?
There will be. So we've just released the NOFO, which is more for the applicants. We're finalizing the instructions to the reviewers. We're also, I think Lachelle is putting together, and she can speak more to it, but she's putting together instructions on the use of the grant software itself, so that when you're interacting with it, you'll have that. That session we're having this Thursday is for any applicants or anybody who's interested. And based on those questions that we get, we'll be putting together kind of frequently asked questions. We may not be able to get to everybody's questions even at that session on Thursday, but our plans are to respond to all of them and put those out on the webpage.
Yeah. And Dr. Ibrahim, that notice of a funding opportunity, it's a 40+ page document. And so there's a lot of detail in that. And so again, after this meeting, again, it's on the webpage, it's available, but I'll have our team send that out and the link out to everybody on the executive committee just to make sure that you're seeing it. Okay, I think we've sent it, but we'll send it out again. Okay. And then Dr. Pliska.
Yes, do CAP residents or psychiatry residents fall under the definition of a postdoctoral person? When I first saw that, I assumed a PhD researcher doing a postdoc, but a resident could submit a policy on a proposal on their own, assuming they had the consent of the chair.
That they are eligible for the funding. Yes, sir.
All right.
Okay. Any other questions? All right, hearing none, again, thank you for all the patience in this, and we will keep the communication channels open and provide information and keep moving it forward. But I appreciate the support from the executive committee. And again, I think it's an opportunity to build the workforce in a way that we haven't before here in Texas. So with that, let's move on to the PeriPan implementation update. Dr. Wakefield could not be here. For those of the members of the executive committee that were here last time, we had a discussion related to an opportunity to partner with the University of Massachusetts in their PCORI grant. During the conversation, there was a lot of support, but they also got the message from several folks that they needed just a little bit more information and wanted to think about it just a little bit before we had the formal vote. Again, Dr. Wakefield can't be here today, but we've provided information to all the executive committee members. Again, this is purely voluntary. It is allow the institutions that are funded through our PeriPan initiative to be able to partner with them as we try to implement PeriPan throughout the state of Texas. And so the motion that Dr. Wakefield wanted to make was to to approve the involvement of any interested Texas Child Mental Health Care Consortium health-related institution that is implementing Parapan to be part of the University of Massachusetts Chan Lifeline for Moms PCORI grant. So that's the basic motion. Again, unfortunately, she can't be here today. You know, I did check with her on a couple of questions that I had. You know, one was, is there going to be any cost to your institution? The answer is no. Are we expecting that your institutions need to dedicate time and effort to the project? And she noted that no additional effort is expected outside of the Parapan time that is already dedicated. It is their grant. And so, you know, the University of Massachusetts will be managing the grant, but they will be willing to come to us on a regular basis to update us on the progress. And again, this is a voluntary allowance of our institutions that are implementing Parapan to work with them and learn their lessons to help improve the implementation of Parapan here in the state of Texas. So with that, I need somebody to, I want to read a motion and I need somebody to make that motion. But again, the motion is to approve the involvement of any interested Texas Child Mental Health Care Consortium health-related institution that is implementing Parapan to be part of the University of Massachusetts Chan Lifeline for Moms PCORI grant. Anybody want to make that? So moved from Dr. Abraham, second by Dr. Wagner. Any further discussion? Hearing none, all in favor signify by saying aye.
Aye. Aye.
Any opposed? Nay. Did anybody abstain? Then we have unanimous approval to move forward on that initiative. Next, let's go. Rachel, we'll go to you related to an update on the statewide expansion of TChat.
I'm going to go through this pretty quickly. Dr. Lopez touched on most of this already. We are currently active in 6,154 campuses across the state. That represents just over 65% of all schools and 70% of our student population. We have four HRIs with onboarding statuses with an implementation date for those onboarding schools. UT Tyler has quite a few coming on board January and February. UTMB, UT Southwestern, and Dell also have schools coming on board in the next few months. We saw increases in active schools in 7 ESC regions. Those are regions 2, 4, 6, 7, 11, 14, and 15. You can see just the overall growth of the student population and schools covered over time. As Dr. Lopez mentioned, of the schools that decline, most decline because they have existing mental health providers available. This is some new data that we've been sharing. This is referrals by month. So you can see that at our highest point for 2023, we were in October, we had our highest number of referrals. That has gone down slightly in December, but we were still 77% higher just in terms of the number of referrals that we were receiving compared to last year. And compared to 2021, it's 131% higher. Here is a different look of the number of sessions and also students served. And you can see that we had a record number of sessions and students served in the month of December. Our total session count is over 115,000. As Dr. Lakey mentioned, in the next month, we will be breaking this down a little further so that we can take a look at those care coordination sessions. Any questions?
So any questions from the group, from the executive committee? So that's the report that we provide to the governor's office and the leadership offices here in Texas. And we added the additional performance, the number of sessions, the referrals, and the latest version of the report. And again, a lot of work, 10,000 sessions across the state of Texas is, over 4,000 referrals is a lot of work, and it just kind of demonstrates the need of these type of services here in Texas. So again, thank you to everyone and to your teams for doing the hard work to get that put in place. All right. Seeing no questions, let's move on. Rachel, we'll go back to you. One of the things that Rachel has been working on is something that we've made up the name TChat 2.0. And basically the concept here is that we're now entering 4 years. We've had ARPA funded initiatives. We need to think through how does that complement what we're doing with TChat? How does it change TChat? What do we go to the legislature for next session? And in order to do that in a comprehensive way, we need to define kind of what this next version after ARPA of TChat is. And again, there have been multiple meetings on this with all the individuals that are involved in the various ARPA funded projects. And again, I want to thank Rachel for doing the hard work of putting this on paper and kind of defining after ARPA, what does TChat look like? And again, conceptualize it as the TChat 2.0. And Rachel, let me hand it over to you.
Thank you, Dr. Lakey. I have a lot to get through, so I would just ask that you all hold questions, and we'll make time for questions at the end. As Dr. Lakey said, TChat 2.0 really is our proposed strategic direction for moving forward and sustaining our growth and ensuring that we can integrate all of the lessons learned over the last almost 4 years of the program's existence. So when TChat was created, our goal was to improve access to care. That will not change. And these core components of the program also will not change. So we are going to continue to leverage the expertise of our HRIs, assure parent and caregiver involvement and consent, offer our services for free, address behavioral health needs early. We want to make sure that our referrals are coming primarily from Texas public schools and give every district the opportunity to receive TChat services. We'll also continue to utilize technology and engage our small and rural districts. So with TChat 2.0, we wanted to make sure that we were, like I mentioned, incorporating our lessons learned during this initial phase of the program and continue to build on the expertise of our HRIs. We really identified a need to create some cohesion among our HRIs to really leverage our statewide network and enable that resource sharing. And we want to ensure continued flexibility with our HRIs to determine what the program looks like while balancing that with some standardization. And we hope that this will help us, move forward to continue to, accommodate the growth that we've seen in the program. So this is our overall timeline. In the early weeks of this calendar year, we have been discussing with some of our TChat HRI leaders and leaders of our TChat ARPA funded projects. Today, we are initiating a discussion with you all so that hopefully next month we can receive your approval to move forward with TChat 2.0. A big part of what comes next is policy development to really codify these decisions and expectations. So we'll be doing that throughout the spring. And we also want to give our HRIs an opportunity to revise budgets for next year, given the changes that we are proposing with TChat 2.0. We'll also be developing budgets for the next biennium with that in mind. And throughout the summer, we'll be refining and finalizing those policies and training materials and other training activities before we begin to launch TChat 2.0 next school year. So here is just a big picture, a picture of what we are proposing TChat 2.0 to look like. You'll see that a lot of this is the same. As I mentioned, a lot of our core components are going to remain the same. One of the biggest changes will be in this middle area of the chart here. We really want to continue to focus on that short-term early intervention, but also use assessment and standard screening to help us determine how best to assist the students who are being referred to us. So that may mean a short-term early intervention following assessment. That also may mean that we jump straight to care coordination. We want to make sure that all HRIs are providing care coordination and connecting students to outside services and support when needed, when that short-term early intervention is maybe not as appropriate for them. The intermediate services is what we're kind of calling our integration of our TChat ARPA funded projects. And we want to make sure that if care coordination isn't resulting in a connection to services immediately, or if there are no services available outside of TChat for that student, that we're able to provide that intermediate services. So getting into the details about the characteristics of our proposed model. Again, we'll continue to be a free service at no cost. We will continue to take school-based referrals. We want our primary source of referrals to continue to come from public schools, but we also want to give HRIs the flexibility to accept referrals from other sources, such as from private schools and homeschooled students when the HRI has the capacity, is able to provide those services. We'll continue to focus on being a quick access services and rolling those referrals as quickly as we can. And if an HRI does not have the capacity to process that referral quickly, then we want to facilitate a transfer to an HRI that does have the capacity. We'll continue to be non-urgent, so crisis services will not be provided by TChat, and we'll want to make sure that we're facilitating appropriate referral or connection to services in those cases. Our services will continue to be individualized based on the strengths and needs of the family and their preferences, and making sure that if specialized treatment is needed, which will be part of our intermediate services, that a referral is made to the appropriate HRI if the child's referring HRI is not able to provide those specialty services. As stated in statute, we'll continue to provide our services via telehealth and telemedicine, and primarily on school campus. But we want to, again, give HRIs the flexibility to offer home-based or after-hours sessions. We'll continue to be child-focused, serving students, primarily those in Texas public schools. We'll also continue to be culturally informed and provide services in the language preferred by the family, and ensure that those preferences of the family are prioritized. We'll also continue to measure family satisfaction. As something new, we really want to formalize discussions that we've been having about standard screening, so that we can be more measurement based as a statewide program, and to help us determine the services that we provide to our students.
And so we are proposing to implement some standard screening assessments at intake. And then for students who are above the clinical range, administer those again at every 3 visit interval. And we also want to make sure that our treatment and services are evidence-based. So we really want all children referred to us to have access to all TChat services, regardless of where they reside. So we again want to maintain that focus on short-term early intervention services, but for students with a higher need, when no other services exist, and the HRI has capacity, we want to provide an opportunity for our HRIs to deliver intermediate services. And if intermediate services are not available in the students referring HRI, then we'll facilitate a transfer to another HRI. We also want to continue to outreach to and onboard the campuses in our state that are currently not active. Getting into components of the program, again, I want to make sure that we're leveraging standard screening and also clinician judgment to make sure that the treatment needs are identified and that we're getting folks in the right place. I mentioned care coordination earlier. Want to make sure that all of our HRIs are providing care coordination. We also want to make sure that our TChat providers, both within HRIs and between HRIs, are coordinated. We want to make sure that our providers are coordinating with students' PCPs and sharing information when a PCP has been named, and then when appropriate, sharing information with the school. We want to continue to provide training and education to school staff and families, and continue to promote the Youth Aware Mental Health program and other resiliency training and psychoeducational offerings. The consortium will continue to provide WellNeti as our centralized resource and referral database, and leverage that for our care coordination activities. This will be especially important as we really build out that statewide network and ensure that our students have access to services regardless of where they live. Workforce development, we really want to promote training and building the workforce overall. So making sure that our clinicians have access to training and that we are recruiting trainees and ensuring that they're supervised and can continue to grow and build that workforce statewide. We also want to make sure that our staff are integrated. So when HRIs choose to provide intermediate services, want to make sure that those are not staffed separately. And that will really also help us to maintain our focus on short-term early intervention when we need to, but be flexible to meet the needs of those students who may require additional sessions. TRAIT will continue to serve as our centralized data management system. We really want to promote the submission of referrals in TRAIT to our school staff. And our institution EHRs will continue to serve as the official patient record. Again, the majority of our TChat services, we really want to continue to maintain that focus on short-term early intervention. Previously, we had defined this as an intake session and up to 4 additional sessions. We are increasing this to provide additional flexibility to HRIs. So we'll now be redefining short-term early intervention to be up to 8 sessions. This will be a choice for HRIs. If 5 sessions are working in your area, that will be fine. We want to maintain that flexibility, but also recognize that there are HRIs who may be more resource limited, and 8 sessions may be best for them. And then intermediate services, again, this is where our ARPA funded projects will fall, and we're calling those our specialty services. We also want to make sure that we have the opportunity to provide what we're calling bridge services to students who may have a need for longer term care or more specialized care, but it's not available in their community. And this will be up to 20 sessions through our intermediate services. If an HRI does not have the capacity to provide this level of service, but another HRI does, we want to make sure that we are, again, facilitating that transfer to an HRI that can provide that service if no other services are available. So what does this mean specifically for our TCHAT ARPA funded projects? Our anxiety, substance use, and trauma services will continue. Again, we want to expand this statewide. That means that HRIs not currently providing these specialty services may choose to provide these services in their area. They don't have to. So in cases where an HRI does not choose to provide these services, we'll make sure that, again, students are transferred to an HRI that does provide the service. Again, this will be up to 20 sessions. And then for our substance use services, we'll have very specific eligibility criteria to make sure that we're not overlapping services offered by HHSC. We have been working with them over the last number of months to ensure that we're coordinating with them referrals to and from those HHSC funded programs. YAM will continue, as I mentioned, and any HRI not currently offering this and providing this in their areas may choose to do so. Our ARPA-funded evidence-based group sessions, we will not be providing additional funding for this, but those psychoeducational group sessions can continue. Extended sessions will continue as an intermediate service. Again, this is up to every HRI to determine if they'd like to do that. Statewide coverage, again, will continue. And our ARPA-funded bilingual services program, the parent support group will be discontinued, but we want to continue to provide linguistically relevant services. Again, here is our timeline. So today we're having our initial discussion with you all, and hopefully next month we'll receive your approval to move forward. We're already beginning development of policies so that we're ready for next school year. We'll be finalizing those at the end of the summer. And delivering training to staff during the summer as well, so that we can, again, begin launch next school year. Okay.
So maybe, Rachel, I'll jump in here. And first, thank you for all the work to put this together. And thank you to the people across the consortium that have been involved in this and the preliminary discussions. I would note that it's marked draft, and because we want to get your input this meeting and then have something that we can move forward in a subsequent meeting. But we've been in this position over the last couple of years of being able to do some novel things with the ARPA dollars and being able to expand the trauma, the anxiety, the substance use services. And we just believe that in order for us to be prepared for the next session, we need to have that conversation now to say what worked, what didn't work quite as well, not to fault the people that did it, but some things were able to move forward and some had some challenges of moving forward for a variety of reasons. And we need to learn from those lessons and use those lessons to incorporate into the overall TCHAT program those lessons and those programs that have been seem to be effective, but also make sure that we're clear that if something really, even though we tried, didn't really land here in Texas, we weren't able to do it quite like we thought we were going to be able to do it, not continue those things and then look maybe at another time on how we can do something similar. But again, this is a iterative process. We want your input. But we need to have those conversations now because it's going to inform how we define our budgets, and then it's going to help define how we go to the legislature. And so, Alan, you've been very patient. I've seen your hand up for quite a while. I wanted Rachel to be able to get through the presentation first, but now let's go to your question, and then Steve, and then Octavio.
Okay,
Alan?
First is I'm concerned about homeschools as being something that we kind of begin to incorporate. I'm not sure how that works. I just want to really think about homeschooling and what services we can provide to the homeschooled person.
Okay.
The second is that, we've worked for the last several years to really come up with a defined initial assessment for all of the people that we serve within TCHAT. And from what I heard from the report is we're still refining that. And I think the consortium really needs to say, this is our basic level of assessment that we can measure across all of the HRIs, that we can then begin to track that data. So if we still have some disparity out there in terms of what we're tracking with different HRIs, I think the consortium needs to say, this is what we say is the basic, and this needs to be done through trait.
Right, very good. Thank you. Steve, Dr. Plitzka?
Yeah, real specific, do I think it says YAM will continue? Does that mean we can anticipate putting in a budget to fund YAM on an ongoing basis, even after the ARPA monies go away? Did I interpret that correctly? That'll be our goal.
I think that will be the conversation we'll have this spring of how many schools that you can provide YAM to, and then we'll incorporate that in the budget request to the legislature, and they will determine how much further we go or not. But as our plan right now is to continue the YAM and to continue to build that program out. Does that make sense, Steve?
That makes sense. One other point, broader point. I mean, we talk a lot about trying to integrate CPAN and TCHAT. We don't talk as much about the integration between CPWE and TCHAT, which continues to, I think, to be more difficult than it should. Like, we sometimes have difficulty getting TCHAT transfers even to the CPWE programs where our own residents are working because of the various bureaucratic and procedural phenomena that occur. And I think maybe some attention to that going forward really would enable us to kind of move people who need longer term care faster, and thus make it easier to take new referrals. I'm not proposing a specific solution to that, but rather maybe a subcommittee or something really, if it hasn't already, that's something we should have a little bit more focus on.
No, Steve, I agree. And actually that was a big part of at our CPAN summit about a month ago. There was a large component of that looking at how do we integrate across the programs, because I think a lot of people feel like you do on that issue. Octavio, let me go to you.
Thanks, David. Rachel, a great presentation. I love, of course, the 2.0, including cultural and linguistic competence and being sort of person-centered, family-centered. To that, though, in some of the things in ARPA that's going to be discontinued is the bilingual support for parents. Could you give the rationale for eliminating that? Was it not being utilized, or what was sort of the reasons behind discontinuing that or winding it down?
So Octavio, let me clarify this just a little bit. What we're saying is that needs to be standard. That's standard across the state of all the HRIs that you're serving individuals and can meet the language needs of the kids. And it shouldn't be a standalone ARPA project. It should be something we just do. Does that make sense?
Yes, thanks for the clarification. It makes a big difference. Thank you, David.
Okay.
Now, Dr. Martinez, for the parent sessions in particular, we did have a conversation with the HRI providing those services currently, and they did feel like it was best to discontinue that. We also want to make sure that we are focusing any kind of parent support, education, training on the child's needs. So we will continue to encourage our HRIs to provide parent support with that focus on the child.
Yeah, but we were given a little bit more flexibility with the ARPA funds. But the statute for the Mental Health Care Consortium is focused on the kids, and that's where we're building our budget and moving forward. Okay.
Understood. Thank you.
Dr. Martin, Sarah?
Yes, I wanted to talk to everybody, but Alan specifically, because we have, for whatever reason, we have a lot of homeschool kids here in our section of the state. And it's actually easier to do that because you take the referral from the parent, they send the consent, you start the treatment. And you really have the parents more on board probably from the very beginning than most of the kids, where it's, their teacher saying they have a problem or their school counselor telling the parent they have a problem. So we've had a really, really easy and good positive experience with the homeschool kids. And also I wanted to say that I think all this is great and I'm ready to vote today, but I know we have it on the schedule for next time, but it sounds really great.
Well, thanks. And I think one of the things that Alan may be wrestling with is volume, how many kids are going to be there, et cetera. And so I think that's part of the analysis. But hearing from your positive experience, I think that's very helpful. Madhukar, Dr. Trivedi?
Well, just to clarify, so this, I think that the things like we are getting these requests, and Steve, Dr. Spliska, I think your team has been amazing, and so they are, and Dell is getting a request from outside of just school districts and this homeschool, but even outside for youth organizations, for YAM and etc. So you guys, all of you, the leaders will have to decide, but I think it's a little broader request because this is real in real youth, and how do we deal with this? So, yeah.
And I think it's this, Madhukar, the challenge that we have for the consortium as a whole, a lot of it is workforce and getting the people here. There's a lot of demand out there for the variety of programs. We're not going to set up anybody for failure, right? And so we need to make sure that we meet the issues of demand and what we can do, and again, give a realistic request to the legislature.
And I thank you for bringing that workforce issue, and that's why YAM, as well as Safety A and behavioral activation, are all the kinds of things that we have proposed through the largesse of my president, is to try to figure out a way to address the workforce issue. Because I think you're so right. We can keep on piling on for the same people who have the expertise, but that doesn't build it. So all of these, YAM is a different workforce. It's not the clinical psychologist, and it's not, so thank you.
All right. Lee Johnson, I see your hand.
Yeah, Dr. Lakey, thank you very much. Really appreciate all the work that's gone into this. Great presentation. Really excited about 2.0 and the future of TChat. I had a question about, there were a couple of references in the slide deck to determinations when other services are not available. And I was just curious if somebody, perhaps Rachel, could expand upon how that determination would be made. And for additional context, as you know, Dr. Lakey and others, our system, we've been working to streamline, to improve referral processes when a child is identified as needing additional services beyond the TChat intervention in the local mental health authority system. And so I'm just curious about, how that determination would be made that there were no other services available for the child. Thank you.
We'll definitely continue to work with the LMHAs, Mr. Johnson, and strengthen those partnerships with community service providers. We want to make sure that we're leveraging the expertise and knowledge of our HRIs to identify those local resources that are available to children in their area. As far as we haven't decided on any details about what that process will look like yet, but I imagine that will come out of our discussion as we put things on paper and really start finalizing things in policy.
And if I may kind of jump in to this, Lee, the goal of our programs isn't to take over all of mental health services, and so that therefore we try to put barriers there, that we try to, from the beginning, start doing the process of handing off the kids to a permanent solution in their community. But it's really hard for some of our institutions, and you know that you live this, that where the state is a pretty much, except for a few counties, mental health professional shortage areas. And so our institutions try, and they, try a variety of means, but sometimes it's taking them a little bit longer. And so this will give them the capability to not drop the child. We never want to have to drop a child as they continue to try to figure out a long-term solution for those kids. And so there are some of these, with trauma and anxiety, where it just seems like it takes a little bit longer. And so we've tried to incorporate those into this intermediate. But again, we don't want them to stay indefinitely in the program, because if they stay longer, we can't get some of the newer kids in. And we're already having some of those challenges of getting some new kids in. And so our folks really are trying from the beginning to do the case management, to find some provider. But in some of these rural areas, you just can't find somebody that has a slot that's available. And even though your folks are working as hard as they can, and other folks are working as hard as they can, they just can't find that. And so I think kind of the answer to your question is that it's being done at the institution based on them working their networks and everything the best they can, with the concept from the beginning of the goal is to hand this child off to a long-term provider in their community. Does that make sense, Lee?
Yeah, no, I appreciate that context, Dr. Lakey. Thank you very much. I just think about the various discussions we've had over the last many months, kind of smaller group sidebar discussions. Dr. Williams, I know you've been involved in some of those, to kind of break through what are those real barriers and what are the perceived barriers. So I just really appreciate the thoughtfulness and the attention to this conversation, and very much look forward to next steps on it.
Yeah, and Luann was just commenting to me, maybe, you and me, and a couple of folks need to have a little bit of a deeper dive into that to make sure we're doing everything we can across the consortium to get the kids in as quickly as we can to that longer term solution.
Absolutely. And we'd be glad to be involved in that conversation. Very much look forward to it. Thank you, Dr. Lakey.
No, thank you. Any other comments? Hearing none. Rachel, we're going to go back to you. You have two more presentations. It's a little bit of the Rachel show this afternoon or this morning. And so one of the things that we've asked Rachel to do is to put on paper a variety of our policies, just make sure that there's clear understanding. And so she's going to have two presentations, one related to that overall process of policy development, but also an issue that keeps on coming. We just want coming up to us, we would want to be very clear on is the research participation requirements and TCHAT, recruitment and TCHAT. And so we're going to talk about this, and then have a discussion on the overall policy development initiative. And so, Rachel.
Okay, so as Dr. Lakey mentioned, we're really going to be pushing forward with a policy development for a number of items, including those that we've already made decisions on. This is one. The legislature set expectations for us regarding research recruitment and consortium-funded clinical programs. So this just codifies those expectations. We do have an expectation that HRIs are not recruiting subjects into research studies from consortium clinical programs. We want to make sure that we can continue to focus on direct mental health services to students, and research is not a goal of the TCHAT program. So just getting into the policy, I'm not going to read everything, but I'll touch on a few things here. We want to make sure that research activities and TCHAT program operations are not overlapping, and that consortium funds are not used for TCHAT staff to recruit research participants. We want to make sure that HRIs are not using their access to schools and students enrolled in TCHAT and other clinical programs as a mechanism to recruit students. Our research staff should not be contacting TCHAT students directly. We also want to clarify that HRIs are permitted to offer research studies as a potential referral source to any referred student whose needs fall outside the scope of TCHAT. But we want to make sure that that referral is appropriate and provided as an option for the family to consider. And then finally, just want to clarify that evaluation is certainly an acceptable activity to assess program effectiveness and identify areas for improvement. And we want to make sure that HRIs are discussing this with our evaluation teams just to avoid any redundancy. I also included some definitions here. I'm not going to go through them, word for word, but we'll get into the review process for our policies in just a second. But just as Dr. Lakey mentioned, really just want to clarify what has already been decided regarding this activity.
All right. Very good. And again, this is draft, so we'll send it out to everybody. But basically, this is stating what our policy has been, but hopefully stating it a little bit better and clear. Because every now and then, even though we've had some discussions, there's questions that come up, and we want to be very clear with what our policy is. And again, it was very clear to me with the legislature that that this is a very unique relationship that we get to have with kids to provide TCHAT. We need to protect that, not use that to build the research programs. But on the other hand, just because a child has been involved in TCHAT, that doesn't exclude them from research projects in the future, especially if there's a need to get them additional services. And so, Dr. Trivedi, I see your hand. Let me go to you first.
So this is a very tricky thing, so shut me down if I'm on the wrong track. But if I'm the father of a 16-year-old who is dealing with TCHAT, and she cannot or does not or is not allowed to participate in research because she is part of TCHAT, it does take away her rights to be able to participate.
So let me clarify there. Okay, that what we can't do is recruit from those programs. Okay.
Right.
If that dad says, I know there's this great project taking place, and independently comes to you and says, I want to be part of that, or at the completion of the TCHAT, and there needs to be additional options, and you list it as an option, and they decide they want to be in it, they're allowed to do that. What we can't do is say we have a list of kids that are in TCHAT, and I'm going to use that as a recruitment tool into the research projects. Okay.
But the reason I think about this, Dr. Lakey, and all of you, is because I've spent a career trying to improve clinical outcomes for people with the treatments we have currently available that should improve their outcomes. We have good treatments that work that are not used. And so the issue is, how do we capitalize on this opportunity? So I'm not trying to complain.
Yeah.
I see it as an opportunity, and I am just I'm wanting to raise it. So please don't ignore. Yeah.
Yeah. And what I think we put on paper, and again, we'll send it to people and get your input, is the will of the legislature related to how we do this. They are funding our programs, and I think have a reason to say that special relationship we have with schools cannot be violated in a way that it perceives that there's a conflict of interest for research projects. That's not to say that those kids couldn't benefit from being part of an initiative, but we can't violate that specific relationship that we have been privileged to receive. And so again, if a child wants to be in it, they can enroll, but we're not going to use our lists of kids, that special relationship as that recruiting tool. And again, it's very clear to me from the legislature that is their desire. Dr. Plitzka? You're on mute, my friend.
So, and the offering would have to be only in the discharge process. In other words, I assume in the discharge process, you could include a flyer for research study along with, here are your PCP can manage the medicine. We're going to refer you to a regular therapy thought in the clinic. Oh, and by the way, we also have this depression study going on, but you couldn't offer that flyer while they're in active treatment. That's my interpretation of what's written in the policy. Is that correct?
I would agree with that there needs to be no perception in the mind of people we're serving that that there's any pressure at all to be part of a research project. Their decision, if they, that they can make a choice, it doesn't exclude them, but there can never be any pressure, and there can never be kind of taking advantage of that, the data that we have, the kids that we know that are in these programs to use as a recruitment tool.
And by the same token, if a family in T-Chat hears an ad on the radio that there's a depression study at HRIX, they can obviously pick up the phone. We don't have to tell
Absolutely.
them.
Yeah.
Then they're fine. Yeah, right.
Yeah. They're in charge of that. Okay. And so the parents are in charge, have control of that, of whether they want their child enrolled. But we will not take advantage of that relationship to recruit them in or have any perception in their minds that that there is any force or that it's your preference. That's their decision. Okay. Any other comments? See none, that'll be sent out to everybody and take a deeper look at it. Again, I think it just puts in a different form what our rules have been and make sure that there isn't any misunderstanding there. And we're going to go through a variety of these policies that we've had in other forms, but we now want to make sure that we have kind of our full book of these rules and policies so that anybody that's new to the consortium, that's stepping into a position, it's very clear to them what the rules are and what the policies are. So Rachel, let me go to you next, again, on the draft process for policy development.
Okay. So this is what I'm calling our policy on policies. This is our proposal to govern the policy development process. And as Dr. Lakey mentioned, make sure that decisions and expectations are documented and available to our staff. So I want to first start by acknowledging that these policies are not intended to replace individual HRI's existing policies and procedures, but we want to make sure that there's a good that there's some symbiosis between those two sets of policies. These will really enable us to mitigate risks, be explicit about what expectations are, and identify where HRIs have the flexibility to make the programs their own. I won't go over scope and policy, but again, we'll send this out. And if you all have any feedback, please let us know. Getting into the policy development process. So generally, this process will involve 10 steps. However, policies that codify our fundamental principles will not require an issue brief or any research ahead of time. The policy that we just reviewed would be an example of that. Likely, most of our TChat 2.0 policies will also not require an issue brief. However, when an issue is identified, that will be either identified or escalated to UT system or the COSH. UT system will research that issue with consultation from COSH. Following, UT system will prepare an issue brief with recommendations and a draft policy to address the issue. We'll then obtain feedback from COSH and revise our recommendations as needed. After we get COSH feedback, we will send that to our internal evaluation team and revise as needed before sending to our HRI leaders, making sure that HRIs have an opportunity to weigh in, provide their feedback. This will also help us determine any timelines for implementation and account for special circumstances that we need to account for. After we've received input from HRI leaders, we will request approval from you all if there is a significant change in program scope or funding. Any policy changes that don't have a significant change in program scope or funding will be provided to you all as an informational item. COSH will then prepare any relevant procedures and training materials that are necessary to implement policies. And then we'll make sure that these are posted on our SharePoint site. We're currently working to set out some new architecture for our SharePoint site to make this more user-friendly. So there will be a place on that new SharePoint site for our policies and procedures to live. We'll then implement our recommendations and the policy. As far as review goes, we want to make sure that we are reviewing these both at regular reviewing to ensure implementation of policies and procedures to make sure that we're addressing any issues that may be impacting program implementations, any program operations. We also want to make sure that we're reviewing these policies at least biannually. UT System will lead that review. And there may be changes needed when the program is at a critical point in growth that has changed or will change program administration or operations. There may be external factors that necessitate changes to the program. And current policy may pose an imminent risk to funding budgets or the program's ability to meet its mission. So we will want to ensure a policy change at that point as well. So we will have a set of deliverables, including an issue brief, the policy itself, the procedure attached to the policy as needed, and training materials as needed. Any questions?
So again, you know, I don't want people walking away and thinking this is the first time we're putting policies in place. We've had robust policies, but a lot of those are in our governance document. And the challenge is you don't want to come up to redo your governance document on our, we do on a regular basis, but I think there's a variety of things we need to be a little bit more nimble on, and then having this put in place separate from the full governance document makes us a little bit more agile. It's easier to make sure that we are moving everything forward the way that we need to, and just clarifies the process. And I think being very clear of the steps that it takes when system does something versus COSH does something versus the executive committee. I think having that very clear on paper will help with communication and making sure that all the steps are done appropriately for every policy that we put in place. So any questions? Okay. Again, it's marked as draft. We'll send it out to everybody. Please send any comments to Rachel, and it's my anticipation both of those will be then approved, voted on at the next meeting. Okay. With that, it is 12 o'clock now. We have a couple more things to do, but how about if we break at this point for 30 minutes and at 12:30 reconvene, and then we will finish. Actually, we can do that, or we could power through for an hour and then just stop. Does anybody have hard feelings either way? Are you guys okay with us powering through for an hour? All right, I'm seeing Alan. I see your hand.
Power through.
Okay.
Bio break.
Oh.
All right. All right. Everyone gets a bio break for 5 minutes, and then we're gonna power through. And then I tell you what, at 12:10, I'm gonna give you a little bit more. 12:10, we will start. I saw all those looks on people's faces. And so at 12:10, we're going to reconvene, and then we're going to power through, and then let everyone go to wherever they want to for lunch. Okay, very good. And there's Lee again. Okay. We're going to get started in 1 minute. So I would encourage people to take their chairs and we'll get started in just a little bit. Okay. So we were at quorum. All right, it is 12:10. So let's go ahead and get started. Again, I think we have less than an hour's worth of additional business to take place today. Dr. Pliska, let me go to you first. Anything on the Data Governance Committee that you want to update the group on?
The Data Governance Committee has two pending items. We've been kind of not had a lot to do recently, but we received a manuscript from Dr. Eric Storch at Baylor, looking at the results of his STEP program. And we've received a proposal request for data analysis from the Texas Tech Lubbock group, looking at their own internal data. And so the management committee will be convening within the next couple of weeks to review those documents and make a recommendation. In the case of the manuscript, the issue is whether we want to authorize Dr. Storch to go forward and submit to the journal. And of course, we'll decide, look at the types of analysis Texas Tech is proposing in terms of A, their appropriateness, and B, any demand that it might impose upon Kosh or trade or so forth. So those are pending items. We've also had some, as you know, David had internal discussions with UT System regarding the structure of the management committee, and we've got an informal proposal, maybe break those committees into pieces, one dealing specifically with data, another dealing with sort of a publications committee per se. But those are still in the discussion stage, not ready to bring to the executive committee at this point. But we'll keep you posted on that.
All right, very good. Any questions for Dr. Pliska? Seeing none, Dr. Williams, let me turn over the virtual platform to you with an update from the Kosh.
Hello, everybody. You're having a good Monday. It's Monday. Waiting. Thank you. Okay, well, my first slide had a cute picture of a golden retriever. February is National Golden Retriever Day. So just wanted to remind you of all the fun things that have been happening in February. Next slide. CPAN, moving on to the next slide. So we wanted to sort of share our overall volume. We continue to see growth, as you can see, between 2023 and 24. We've added about 100 extra consults between each of the January months. We did also, Dr. Wakefield wasn't able to be here today. I don't have a slide for it specifically, but the PeriPan data also is seeing a nice growth. We had our best month ever for PeriPan as well in January with 99 consultations within the PeriPan program. So we're continuing to see growth. I do want to point out sort of the number of clinics that we have across the state is close to 2,464 clinics within the state of Texas, with around 12,400 providers. That includes physicians, NPs, PAs, residents, fellows. And so kind of going with that information that the external evaluation was sort of sharing with us today, we very much see that our goal is, even though we've enrolled quite a number of people across the state in quite a number of clinics, it is still the case that we find many times that providers tell us that they don't know about the service. So we actually have a project planned for the next couple of months, a QI project to kind of address that. But we do have, again, continued growth within our CPAN and PeriPan teams. Next slide. When you sort of look specifically about our access program, again, we're looking at CPAN here primarily because PeriPan is in a different phase of their growth. But the things that we're going to talk about for CPAN also are things that we are working, sort of that lessons learned idea that our external evaluations team and Dr. Lakey always speak to. Most everything I'm talking about with CPAN also is applicable to PeriPan, but since we're a little bit further along, I'm just showing you data related to CPAN. So this is a snapshot of January, and you can see the total volume of consultations in that month at 1102. And then you can see what percentage of those consults included one of our child and adolescent psychiatrists in CPAN, which is about 34% of the overall calls included the physician speaking, collaborating with the psychiatrist. So that's good, but we still feel like that number could increase and become slightly better. The other thing that we also want to look at, because we're an access program, part of where I think sometimes people kind of get lost in all the great things that our service provides, we're honestly about providing access to include encouraging the care when it's appropriate to be done within that primary care space versus just making a referral to a psychiatrist that's actually not available. Because as we know, looking at the map that Dr. Lake even spoke to earlier, it's a bit of a desert across the state. So again, if it's feasible and practical and appropriate to have the physician, the NP, the pediatrician, family physician, OB, providing the care within their own clinic, it actually helps people get care quicker, with less stigma and less sort of onerous going between multiple visits, multiple appointments. So we wanted to look specifically at how often is our own CPAN team helping find a psychiatrist for the physician provider who's calling. And you can see in the month, we had 138 times where we were asked to help them find the physician. Now, our goal is never to not provide that referral potentially. If the physician really says they want us to help with that, we will. But what we feel like is important for us to do is actually encourage a collaborative conversation with the colleague. So the physician who's asking for that referral that may take weeks or months, to have and make sure they have a conversation, a consultation with our psychiatrist and our perinatal psychiatrist as well. So when we wanted to see, well, what percentage of the time of those referrals that we look for, do they actually speak to one of our psychiatrists? And you can see here it was 28%, which again is a percentage that we would like to kind of work on and see get higher of sort of that sort of piece of it. And then finally, you see at the bottom is just the number of direct consultations that were provided in the month of January across the state, which was at 22. This is across all the HRIs. It's not specific to any one HRI. So from our perspective, we envision that as we bump that first 34% number up to have more of those consultations include our physicians across the state, and definitely more of the time when there's a request for finding a psychiatrist or a perinatal psychiatrist, that we have more of those conversations and be a physician-to-physician conversation, that we will also see the direct consultation volume increase as well. And so this is, again, applicable to both CPAN and PeriPan, this goal to really make sure that we're providing it one of the things that CPAN and PeriPAN are meant to do is teach the providers to gain knowledge and skills so they can sort of do the work within their clinic. And sometimes they don't know the questions they don't know to ask, which is why we really want to make sure that we're making those connections more specific and more frequent within our overall volume of consultations. Next slide. One of the things that was really helpful, we were really appreciative of the summit. I think the feedback that we have been getting within our individual meetings with the HRIs is they really did enjoy the summit. Lots of good feedback about it. So the UT system did a phenomenal job sort of putting that summit up, and a lot of good work came out of it. But what specifically came out of the summit outcomes for us related to COSH is that we're working on additional ways to collaborate within our coordination across the teams. Many teams have their individual sort of daily huddles to kind of work through any operational concerns they may have on any given day. Somebody's out unexpectedly, there's a direct consult that needs to be handled. So somebody needs to step away to do a CPAN or a PeriPAN ethics presentation. So there's often things that just need to operationally kind of be managed at the front of the day. So we're going to move forward to also having a daily across-state leadership huddle. Edith is working with the teams right now to kind of set up that first set of them, along with a sort of a schedule of what specific items are going to be reviewed. This kind of meeting can be as short as 2 minutes if there's no major issues, no unexpected problems, to 5 or 10 minutes, and then sort of offshoots of that mean to really make sure that we stay collaborative. Again, we're one team that has 12 sites. So we want to make sure that if one team is struggling in one area, all the other teams are aware and can kind of swoop in and provide support. And this becomes obviously even more important as PeriPAN has been incorporated into our services, that we are providing a lot of outreach efforts that include going out and doing CME activities where providers may be not available. So we want to make sure that we can always get to those phone calls quickly and get the work done that's asked of us from the state. We're also going to start having quarterly statewide meetings that will potentially be specific to the type of role that the provider is doing. So one thing we found within CPAN is we have behavioral health specialists, we have resource coordinators, we have physicians, and they all work together as a team, but sometimes they really want to learn from just specific other team members within the role that they provide. So we're most likely going to be developing some quarterly meetings that kind of get those groups of people together with the CPAN's sort of COSH team sort of assisting them. There's also an opportunity for people to sort of talk about, hey, can we sort of review some material by book club sort of activities to kind of help us kind of learn from each other, learn from sort of some good work out there that's done related to services, leadership, other kinds of things. So that's one thing that we'll be looking to do. And then finally, a CME work group. We are again trying to drive efficiencies whenever possible and sort of use all the expertise across the state in the best, most efficient way. And so some of that work may mean kind of developing a work group that will help us think through how best to sort of continue to provide that really excellent CME that the external team found that many physicians obviously value greatly. And how can we do that more efficiently? So those are some of the things that from the summit, COSH is immediately kind of working to implement to sort of help the program overall. Next slide. So, so this is in reference to the project I was talking about. And sort of it folds in very nicely with what the external evaluation team found when they did their sort of surveys. So I'm glad, thankfully, I was glad to see that those things looked similar, and there wasn't some things that we were kind of not knowing about or not knowing that we needed to kind of continue to work on. So one of the things that we've been hearing from our consulting experts with Lifeline for Moms and MCPAP program overall is just sort of we need to do more in outreach that relates specifically to physician to physician. All of the teams are doing a phenomenal job going out to clinics, dropping off materials, talking to staff, getting physicians and providers enrolled in CPAN. As I said earlier, we have over 2,400 clinics with over 12,000 providers. But what often happens is that the provider themselves, being so busy, doesn't always know that they're enrolled. They don't always know all the services that are provided. And so one of their sort of comments with improvements is they don't know how to use the service. Like they don't know how they could fit it into their busy workday and sort of which would then help them maybe utilize the service more. And what we've discovered in sort of talking with our experts, including our communications team with Lainey and also the external communications team that helps primarily Melanie Susswine, is that more of these conversations that happen that are physician to physician, we believe will increase the ability for physicians to sort of start using the service. So we planned a QI project to do this very specific targeted outreach that is physician to physician. So we aim to start with the first week of March. Every HRI will be provided or already has the list of providers that are currently enrolled in the service, but have not yet utilized the service. So we are only talking about providers who have been enrolled in CPAN. And that list is different, obviously, with each of the HRIs, but about we have a certain about 40% of people so far have not used the service just yet, to that sort of earlier appointed external team. So the goal will be that we will have the physicians during their CPAN time. We're not asking for any of our psychiatrists who we know are extremely busy. So nobody's going to be asked to do this work outside of their CPAN time. But during the time that they have their sort of tour of duty, whether it's a half day or a full day on CPAN, they will be working through this sort of list, contacting directly through phone calls to physicians to sort of hopefully have a conversation with them, either to maybe do their very first CPAN consultation, but if nothing else, have another physician who kind of explains the goals of an access program and how CPAN, PeriPAN work, so that the physician hopefully has greater awareness that CPAN, PeriPAN is in existence and what the services that we can do that can provide for them. The goal will be to continue to sort of on a continuous loop, reach out to physicians until such time that there is a connection made. We have created a spreadsheet that will sort of track this information for the CPAN teams, and sort of Edith will kind of be overseeing that sort of broadly speaking. We've certainly gotten feedback from our CPAN physicians about sort of they would like some support and training related to how to do these sorts of contacts. So Dr. Wakefield and I, along with Lainey and Melanie, have created scripts in addition to having videos, so that providers, our physician providers in CPAN, if they have some uncomfortness or just feel like they don't know how to do this, or they just need some additional support, they can watch the videos, watch the scripts. And then finally, as part of the sort of COSH sort of upgrades related to communication, we had been having twice a week, every other month meetings with the physicians across CPAN. What we're going to do moving forward is actually each month, I will have 1 week of the month where every day, twice a day, I'll have a quick 30-minute meeting. So anybody who's on CPAN or PeriPAN at that time can speak with me directly, so that we can talk through any concerns they're having, any wins they're having, so we can kind of better support the physicians doing CPAN. And the expectation will be, if they're not taking a phone call or providing a direct consultation, that they would come onto this meeting and get to know their colleagues across the state and sort of answer any questions. And then finally, I will be meeting individually with any physician and any of the HRIs who still feels uncomfortable with providing this sort of outreach. But we really want, and I joke about this sometimes, but I'm not really joking, we sort of tell our physicians in CPAN we need to make 600 friends. So we really want to sort of continue to embody that idea that it's easy to contact CPAN, that we are, to the external team's point, we're friendly, we are non-biased, we're non-judgmental, and we're just here to help you. And we want to make sure that physicians are aware of it and how they can use the service. So this goal for this project is obviously to get more of those physicians who are not aware of the service to become aware of the service, with the ultimate goal, of course, for them to utilize the service, and for them to start helping the kids and the women in their practices who need more primary care, mental health treatment and support. It's a lot, but we're ready for it. Next slide. So we are working on the direct consultation process. The work group just saw the sort of mock-ups for the process end to end to do the direct consultation piece within the TRAE platform. The feedback was uniformly very positive. They really thought that all the details that they had asked for to be incorporated were incorporated, and a few they hadn't even thought of. The next step for us will be to have the evaluation teams, who obviously need to get the data from the platform, as well as the CPAN leadership group, to review the stated look for the build out. Depending on those two groups, whether or not there's additional things that need to be refined or worked on, we aim to have that sort of get approval for design so it can go into production to be built. And so then we'll be able to give you a better estimate for when it will be available. We also have the work group meet that was talking about this sort of incidence of PCP who has somebody in their office calling on behalf of the doctor. So we're just sort of improving that process within the data management system. Again, the work group that met around that was uniformly happy with sort of the proposed improvements. So the next step will be to have, again, those evaluation teams and the leadership group review to make sure that they sign off on it. And if they do sign off on it, then obviously moving forward into production. The other thing that we're doing is we are speaking into that external evaluations comment about, I don't know how to fit this in my day, or I would like, some additional ways to get some materials. We are moving forward with the build design for a PCP web portal. This could again be another way for the physicians to be able to put in a consultation request that could be fielded by the team. It also would allow for us to have an ability to send out the recommendations that were discussed in the consultation, both the phone consultation as well as the direct consultation, so that physicians can have an easy access to that information. In addition, we provide a lot of resources, not just the referrals, but resources. There's another way for them to have a secure platform for them to get that. So we understand that not every physician across the state would want to use a portal, but we have a lot of, I think, enthusiasm when we went and met with providers across the state who had not yet used the service, what would be something that might entice them to use it, was the idea of being able to put in a consultation, not either via text or phone, but through a sort of a web process. So that is also in design right now. There's also been a request to add a unique identifier, and we're defining the requirements, as well as how to put out the PCP and experience and engagement surveys out through the trait platform, so that it would just be an automatic feature that was done when a consultation is complete. So those are also currently in defining the requirements. Next slide. Moving on to our T of the chat. So similar to what you saw with Molly and Rachel earlier, we are continuing to see a significant growth in the number of referrals from year to year as it relates to T-Chat services, which of course we're all very excited about. Next slide. When you look sort of again at the reasons for why youth are being referred, again, there could be multiple reasons, so that they don't have to just pick one, but a school counselor, again, the most common reason is anxiety, followed by depression and then anger. As you can see here, there's, of course, still significant number of times where they're saying that this is for relation to trauma, sort of speaking to the T-Chat ARPA programs, that are related to anxiety and trauma specifically. But we still also have a not insignificant amount who are being referred to us related to concerns for suicide. So again, we continue to see that the youth that are sort of being referred to us generally have more than one issue and are really struggling. So I think that sort of speaks well when we sort of saw the external data, how well the families continue to feel that the service has really provided a great source of relief and improvement for their child and their family. Next slide. Again, when you look specifically at the sort of sessions and the who is providing the sessions, you can see that to the right is the cumulative total. Again, these numbers are preliminary and can be subject to change, but it's the sort of sense of the cumulative total sessions. It's pretty amazing, is the word I would use. As you can see here, this is within our our T-Chat teams. Here are the types of providers who are providing the services. So again, by and far, the largest amount of services that T-Chat provides is a psychotherapy, an evidence-informed psychotherapy, as that is the sort of recommended first-line treatment for most mental health issues and concerns for children and adolescents. As you can see here, but we still have a significant number of psychologists, and then a less utilized but still necessary team members are our psychiatrists and nurse practitioners and physician assistants. Thank you. So TChat continues to sort of assist in that sort of one-on-one support. Rachel and Jen work very closely together. Jennifer is frequently assisting, just like Edith does for CPAN, for frequently assisting TChat teams outside of our one-on-ones to kind of manage. We are in that sort of surge part of services for TChat, as we talked about for many years. TChat is sort of has a bimodal distribution of when we get the most of our referrals, and we're kind of coming into that phase right now. We've had some teams already sort of be at their level of capacity, and they've been reaching out to us. And so one of the things that we've done is we partner with other HRIs to provide the ability to transfer referrals over to another HRI that does have capacity, so that we don't have to have the kids waiting for too long to get our services. So we monitor that capacity across the state. We connect HRIs to other HRIs that have capacity. And we've been doing that, and it seems to be going reasonably well. So when you go to look at that TChat 2.0 sort of conversation, this is really sort of this sort of piloting of that process of moving referrals to places where there are resources that are capable, and then moving further with the TChat initiatives of ARPA being folded in. If one HRI is perhaps not doing one of the ARPA funded programs moving forward, they would then be able to refer after an assessment was done, in a sort of a sense that we cannot find this service anywhere else in the local community. And so now we're going to refer them to another HRI that does have that capacity. We have been working with teams to refine what is the sort of the definition of case management care coordination to ensure there's consistency across that data that's provided. And we are working to sort of integrate back to the external evaluation team's feedback, which was really wonderful to see. We have certainly heard from HRI schools and HRIs themselves that they want to have more efficient processes related to making referrals and sort of working the referrals through from beginning to end. So we have 2 work groups that have been working on that. We plan to have sort of hopefully final sign off on the improvements to the data management system to the TChat leadership team this Friday. And hopefully there'll be some yeses so we can get clear on what things need to be improved as we get ready to sort of have our start of TChat for the next school year. We are continuing to support any training. The other piece related to feedback from the external evaluation team, which we really did appreciate, is the question of schools wanting to get more information themselves. I think that the sort of point of what kind of information can we provide back to the schools? Again, we want to be clear that this is healthcare, and the parents guide that conversation. The parents allow us to decide which information to share, which information to not. Obviously, we always work to encourage families to share with schools, but that is ultimately the family's final decision as far as what they want us to share or not. So that can sometimes be an area. We also did meet with sort of the UT systems sort of legal team to sort of talk through what type of information can we share in a more programmatic sort of population health level. And so we have defined what that will look like. And so there will be additional information within the trait portal for schools related on sort of what role the person has in the child's referral. And so there's different levels of ability to view certain things that we do think the schools will find enormously helpful. But we certainly appreciate the feedback, and we always are looking for ways to make sure that we are connected as tightly as we can to schools, just overall efficiency wise, but as well as related to care and that moves forward beyond the sort of episode of treatment that TChat is. So thank you for that. Next slide. So as I said, we are finalizing those recommendations for the referral triage and processing. The UT system, as well as COSH, did support the Massachusetts Association for Mental Health. Luann frequently says this, and I'm just going to say it again. Texas is, and Dr. Leakey does as well, Texas is doing some things that are so phenomenal that other states are taking notice and wanting to learn from us. So Mass is just the latest state that's wanted to sort of talk with us more specifically about how our services run. So they had a visit in Austin, and they met with the UT system team, and I think some of the HRIs, and then they also came down to Houston and met with us in the UTMB, UT Houston, and Baylor HRI TChat teams were able to speak with them. So that was really great. We do continue to coordinate with the communications team on how we can best provide information to schools about the services. As TChat 2.0 gets finally fully defined, we obviously are going to be working very closely with Lainey and the CHG team to really make sure that we develop materials that really highlight what TChat is and how it can help. And we always continue to get communication submissions and provide feedback to them. Next slide. So some of the data platform initiatives, the CIS, the Columbia Impairment Scale, automation has also gone live. We did the first step of automation at the visit 1, and now this is for the automation of this reminder to complete the Columbia Improvement Scale after the 3rd visit. That has gone live. We have done updates to the referral form to have more accurate data when we archive. We've also done some reorganization of diagnosis data at the end of care summary to make sure that that process is as accurate as possible. And as I said, we are also, just like with CPAN, we are working on potentially having the survey that's asked of them by the internal evaluation team to be just sort of automatically sent to families at the end of care when that end of care summary document is signed off on. And then finally, as I said, the school portal dashboard expansion to kind of address that issue of schools getting more information, making sure that we had all the players discuss what information we can share at a population health level. There you go. Questions?
All right, very good. Any questions for Dr. Williams? Steve?
On the outreach by the CAPS to the primary care doctor, you said you try until contact is made. Now, if a CAP calls and the staff say, we've got your message, we gave it to Dr. PCP, he or she will call you back. Does that constitute a contact? Because it could be, I don't foresee, you're certainly not wanting us to call multiple times in an attempt to bother them, really. If they got the message, either they call us or they don't.
No, so we are trying to, again, very much, a good question, Dr. Pliska. We are very much trying to take information, lessons learned. It's simply not enough for us to sort of say another person that's not CPAN relay the information. So we actually are directly going to be reaching physicians. We're going to be asked, we imagine that most of the time we're going to be sent to their voicemail. They may or may not call us back, and that's their choice. But we've gotten a lot of feedback. The CPAN Summit was very instrumental in this, where the providers that came were like, you're not bugging us. So again, we do feel like our skips are very clearly worded that this is not an emergency. They don't have to call us back. And we anticipate that many won't call us back, but enough of them hopefully will call us back that we can have a conversation that's physician to physician.
And if they call back, obviously the person who called them is not on that shift, then they speak to the person, whatever shift they're on.
Yes. So we are not going to make them wait a whole week for you to be back on service. If we're going to leave the number that will be left for them to call back, we'll get them to reach a physician, one of our CPAN physicians the next day, if that's when they choose to call us back.
I mean, we'll need to keep, as you call it, as a QI project, we need to keep very clear. I mean, this could easily go in a different direction from what we're anticipating. That we might get very negative feedback that, why aren't you guys just, we'll call you when we need you. It's kind of like, I remember once our consults were dropping off. So everybody went out to say, can you send me some consults? And the reaction was, why? You don't have enough work to do? So I'm just warning that, physicians are a different breed in terms of with this sort of thing, and we should be very cautious.
Yes, I think that is definitely our goal. We definitely want to be mindful of physicians' time. But one of the things that, again, I think we've clearly discovered is that physicians are not aware the service exists. The external evaluation teams data tells us that. Our own internal review of physicians across the state also tell us that. We actually at the summit, one of the super users for CPAN, who came and did a lovely sort of work helping us think through what pediatricians and family and OBs are thinking. The super user was not aware that we provided direct consults, and they were so surprised and so excited. And I was like, how is it? And again, it was very lovely that they said that because it helps us. But we blasted out on social media, in emails, in flyers, we mail things, we go to people's offices. And I think what we're discovering is what everybody discovers is that to have this many people sort of, whenever they're able to find time in their day to think about it, we have to catch them in that sort of time, and that's difficult. But the goal is not to annoy physicians. Again, the scripts are very carefully worded, so that if a physician chooses to not call us back, there's no harm, no foul. But we simply do need to have more physicians become aware of the service. And we want, what we discovered and what we've heard from experts in sort of outreach is that it's a physician-to-physician conversation works the best. And so we are going to test that out with the QI project.
Dr. Trivedi?
I think that what you have is created is an amazing system. And I think that the largesse of the legislature and the TCMHC has now created this. One of the big things that we have to start thinking about is what that helps us actually solve big things. So one example, a lot of your kids coming to you have anxiety, and in the field in child psychiatry, as you know, Dr. Williams, is struggling with figuring out why in the US, depression is rising constantly in this population, while the rest of the Western world is actually stable. They treat their anxiety with a much different approach than we do. Most of our approach is psychotherapy, exercise, but no anti-anxiety agents. They actually use anti-anxiety agents, and their rates of depression are not as high as ours. And this is tricky for us as a clinical enterprise, but I think it may give us an opportunity because we are actually running into where we are not treating anxiety in kids as efficiently as we could, or at least as Europe and Asia does. And as a result, or maybe unrelated, we have a higher rate of depression in these kids overall. Is there an opportunity? So sorry, but I see it as an amazing opportunity, but you've done a wonderful job. So it's an opportunity. So.
Very good. Olga?
Hello, Dr. Williams. Have you, I know we've seen this before, but I didn't know how often it comes up when the data is broken out by age group in terms of, is it the primary, elementary school kids, middle schools, or high schoolers, kind of what's driving some of these by age group? I know I've seen that before, but is that something that you present periodically?
We do.
Okay. Okay.
Not this time.
Okay. Thank you.
Mm-hmm. Every time we do, it tends to actually just naturally fall in thirds, that a third are elementary, a third are middle school, a third are high schoolers. This disbursement is typically, again, like you would expect within children, adolescents, there tends to be a little bit more of a gender, more girls than boys. But the younger kids, it gets a little bit more equal, as you talk about like disruptive behaviors in elementary school, sort of piece. So the data, whenever we do look at it, kind of tends to fall in the ways that you would not mostly expect it. The one thing we were very happy about with the data we looked at, the internal evaluation team to help with this, was that we were serving people across the different racial and ethnic groups. So we didn't see at least any signals that we were not reaching, kids across this sort of spectrum in that regard.
Thank you.
And Laurel, if I remember this right, the demographics for TCHAT are almost an exact match of the demographics for the state of Texas.
It was across the state.
Within, fractions of percentage points.
Very much so.
Okay. Any other questions? Seeing none, again, thank you, Laurel, Dr. Williams, for all the work that you're doing. We have one more presentation and on an update on the ARPA funds. And Sarah, let me turn it over to you.
Hi, everyone. Sarah McLaughlin with the consortium. I'm going to be providing a couple of ARPA updates today. The first is going to be on those TChat ARPA projects. This update is really just going to complement and add more detail to what Rachel was describing in TChat 2.0 and those intermediate services. So over the past month or so, we've been able to meet with participants in HRIs who are completing those intermediate services such as substance use, trauma, anxiety, and group to determine the viability of those projects, the flow, and those opportunities to standardize as we move to TChat 2.0. We've been able to create high-level drafts of the continuing projects. And so far, most of them have been outlined and reviewed by HRI leads, with the anxiety one being last and due today. So once we have that final one today, the internal team will review, consolidate, and share the draft before the final version to assist with that budgeting. Now that TChat place is fleshed out a little bit, we're going to look at CPAN and CPWE next. Dr. Pliska, I think you brought that up. How do we start to integrate all three of these programs? So just like we did with TChat, we're going to be working on a draft internal outline that we'll review with HRI leads participating in those CPAN and CPWE expansion projects. And with TChat complete and those complete, we're going to look at the most efficient way to integrate and get those outcomes that we'd like to see based on the HRI feedback. And then moreover, we hope that this helps with planning and budgeting this spring for the next biennium. The only additional ARPA update I have is that we've been able to complete a lot of our Q2 meetings, but I am still waiting on a few HRI leads on their project. So we're looking forward to getting this completed and then moving into Q3.
All right. Any questions for Sarah? All right. I don't see any. With that, I think we're at the end of the agenda. Is there anything else that we need to touch on that's on the agenda? Any clarifications for things that were on the agenda? All right. Very good. So again, thank you for your time. You'll get several updates from us. The draft initiatives that we talked about, TChat 2.0, the research recruitment policy, and the process for policy development. We'll send those out. The goal will be to approve those at the next meeting. And then the information on the new and emerging Children's Mental Health Researchers Initiative, we'll send out.
Send it out.
It looks like Nagla has already sent all that information
Already sent.
All right, very good. And if there's any questions in the meantime between now and the next meeting, please feel free to reach out. Great to see everyone. Have a good rest of the day. Thanks.
Thank you all.
Thank you.
Thank you.
Thank you.